I'd like to talk a little bit about success rates in assisted reproductive technologies clinics. This is a confusing subject, and many patients really feel that they don't truly understand what leads to a successful outcome and what are some of the factors that can be controlled and those that can't be controlled. First of all, I think it's really important to individualize your care. In other words, when you come in, we'll look at many different factors that are associated with success rates. We will first, of course, try to figure out why it is that you're having difficulty becoming pregnant. Our general goal is to try the least invasive, least aggressive therapies first, because these are less invasive and less likely to cause complications. However, it's always good to know that later on, if you don't get pregnant with the more conservative, less expensive and less invasive procedures, then you will be able to get pregnant with more aggressive therapies. And generally, we have very good success rates as you progress. First of all, let's talk a little bit about success rates. You can actually manipulate success rates based on what you use as the starting point and then the outcome. For instance, if you start with just an embryo transfer, by which point you've gone through many steps and many patients have fallen out by that point, and then you look at just being pregnant rather than taking home a baby, your success rate may appear higher. Many patients have miscarriages. Many patients actually don't successfully get to the point where eggs can be retrieved, fertilized, and embryos developed. Therefore, the conservative approach that we like to take is to identify patients who start a cycle and take home a baby. That's really the most rigorous way of doing it, because those patients have a realistic expectation when they come into a cycle, how likely is it that they're going to become pregnant. The other way to manipulate data is to actually use more aggressive therapies sooner than you need to. For instance, most of our patients start off with conservative approaches using oral agents to stimulate ovulation and what we call superovulation, where we try to achieve multiple eggs to be ovulated. However, if you start off with IVF as an aggressive approach, you may take patients that would have gotten pregnant with the easier approach and certainly get them pregnant with a more aggressive approach, but that was not necessary to do the more aggressive approach from the very beginning. So you can certainly try to move patients through quicker. What we like to do here at the Advanced Reproductive Medicine is to individualize your care. When you come in, we'll look at your data. We'll get more data if needed. And for instance, if you have ovarian reserve screening, which tells us the number of eggs that you have and how likely it is that you're going to ovulate, then in those cases, we will use that data if it's recent. But if it's more remote, we'll try to get it again, because this is something that changes over time. Similarly, if there are other tests that have been done but were not completed, then we will repeat those if necessary. But if everything has been done, we'll go ahead and identify what your chances for getting pregnant are and try to individualize your care using the most cost-effective, least invasive approach first, recognizing that we can move on to more aggressive therapy if the need arises. So you can be assured that coming here to Advanced Reproductive Medicine, we will individualize your care and use what we think is going to be most effective, but not necessarily the most aggressive or expensive at the very beginning. And hopefully you can get pregnant with easier techniques, but recognizing that we can actually get more aggressive later on. Thanks, and I look forward to meeting you.